نقلت الأسئلة فعلا. خلينا نتأكد. تمام.
بصراحة ما لحقتش أغير حاجة، فهو نفس التوك اللي معاك.
طيب هنبدأ إن شاء الله. إحنا خلاص دلوقتي تقريبا اللايف ستريمينج بدأ دلوقتي. خلينا طيب أعتقد إحنا كده we are live. بسم الله الرحمن الرحيم. Good morning, ladies and gentlemen. My name is Dr. Abdel Hamid. I'm the founder of Sahaskai UK. It's the first world-class forum for Arab doctors. Sahaskai was born in 2020, and over the last year, probably 15 months, we've managed actually to help around 10,000 doctors and patients to help each other. One of the objectives in Sahaskai is to connect Arab expertise all over the world. And today's meeting is our first step on this path to match UK consultants with their counterparts in the Arab world. We are so lucky today to have one of the most prominent Arab experts in acute medicine in the UK, Dr. Nihal Abu Saif. She's a consultant of acute medicine at Heartlands Hospital, one of the biggest Birmingham University hospitals in the UK. She's also a fellow of the Royal College of Physicians. صباح الخير الزملاء الأطباء والطبيبات. أنا دكتور أحمد العوضي، مؤسس موقع سكاي. نأمل إن شاء الله أنه يكون واحد من أفضل الورلد كلاس المنتديات العالمية للأطباء العرب. سكاي اتولدت في 2020، والحمد لله يمكن خلال السنة اللي فاتت ساعدنا أكثر من 10,000 طبيب ومريض إن هم يتواصلوا مع بعض. واحد ربما من أهم الأوبجكتيفز عندنا أو الأهداف بتاعتنا في سكاي إن احنا نحاول نساعد على التواصل بين الخبراء العرب الموجودين في العالم بشكل عام يعني، وبين أقرانهم الموجودين في بلداننا العربية. النهارده الحمد لله يمكن احنا محظوظين بتواجد يعني رمز من اهم رموز الاكيوت ميديسن في بريطانيا، دكتوره نهال ابو سيف، استشاريه الاكيوت ميديسن او الطب الحرج في مستشفى هارتلاند في برمنغهام. هي ايضا زميله الكليه الملكيه للاطباء. يعني without further ado, over to you, Dr. Nihal, if you would like to introduce yourself, and then we can kick off with the presentation.
السلام عليكم ورحمة الله وبركاته. زي ما الدكتور أحمد ربنا يكرمه يعني قدمني. أنا اسمي نهال أبو سيف، و I am a consultant in acute medicine in Heartlands Hospital in Birmingham, which is one of the university hospitals in Birmingham. And I know the Sahaskai website from last year. It's a very promising and fascinating website, to be honest. يعني when I joined it, I have the pleasure يعني to join and be a member of the Sahaskai because it's approaching our colleagues in all Arab countries, and especially Egypt, having a background in Egypt. And we are trying to approach all doctors in the Arab world and even the non-Arab speaker doctors in order to promote a lot of functions like the online clinics and online consultations, and now this project of introducing the lectures on this website will help us to also promote education and training. And we hope that this is going to be an interactive session. I know in the beginning I'm planning to give more the talk as we're going to go through some of the theory based on heart failure. I hope it's not going to be too much information or maybe less than your level, but it's just the newest information about heart failure and classification and new management. And obviously, if you have any questions, please write them to Dr. Ahmed, and he will transfer them to me, and we'll try to answer them at the end of the lecture. So I'm going to start now my lecture, and I'm going to share my screen with you. I hope all of you can see the screen, and maybe
we can see it, Dr. Nihal.
someone Yeah, okay, that's fine. So today, as I said, I'm going to talk about heart failure, how to diagnose, how to treat, and the new classification. There are a lot of basic information in the lecture, but just as you know, I didn't want to build to a very high level. I thought maybe the audience will be a mix between, you know, like some junior doctors or a little bit senior. But if you feel later on at the end of the lecture that it's not appropriate to your level, please also type a text and I will consider it next time. Um, so my objectives of this talk is to talk mainly about epidemiology and then understand the different types of heart failure, new classification, how to approach a patient with heart failure, how to treat decompensated heart failure, as we always do, and then how to treat the acute presentation of heart failure, like acute pulmonary edema. And then for chronic heart failure patients, what are the new options and medications and innovations for the treatment of heart failure? As you know, the failure is one of the most common widespread diseases as a chronic illness. And it's the most frequent cause as well of acute hospitalizations in people above 60. 5% of all medical admissions, so you can imagine it's a very big number. Mean stay of patients in the hospital would range between 10 to 12 days. Here in the UK, we're very concerned, obviously, with hospital stay because it means that these patients will require a lot of nursing supply, a lot of carers, a lot of help with rehabilitation and physiotherapy. It's not only giving medications, but in England, we look at the patient as a whole, and we always try to treat other associated conditions, because most of these people, they are old people, and when they come, they have other problems at home, and being in the hospital would create more problems, like in their mobility or development of bed sores or things like that, or in hospital-acquired infections. So it's a very poor prognosis for these patients to be in hospital. And the prognosis has been even worse than all common cancers. If you imagine, like, the heart failure is can be much worse than cancer, except for lung cancer. 50% of the patients can be readmitted even after discharge within 6 months. This is just a taster case to check your understanding of heart failure. We'll talk about a regular patient. He's 70-year-old man presented with worsening shortness of breath and bilateral leg swelling. He was known to have type 2 diabetes, hypertension, acute myocardial infarction 2 years ago. And he had also a PCI with 2 stents. He's taking all the regular medicines, you know, for heart failure: bisoprolol 5 milligram, ramipril 5, amlodipine 5, aspirin, and simvastatin. He reported shortness of breath at rest and decreased exercise tolerance to 10 yards. He's also been orthopneic, and he has paroxysmal nocturnal dyspnea. No chest pain or palpitations. Then he noticed more increase in the leg swelling and inability to fit into his shoes. He's an ex-smoker, which he stopped 40 years ago, and he doesn't drink alcohol. He lives alone, independent. On examination, his observations were fine apart from some tachycardia. And he's got bilateral leg edema, increased jugular venous pressure. He has mild abdominal distension, sacral edema, and bibasal crackles. As you know, this is the most common symptoms and signs of heart failure, which you always see. Like people come with shortness of breath because either they have pleural effusion or pulmonary congestion, or it can reach up to the pulmonary edema, which can lead to an acute stage. They have the coughing because of that as well, swelling in the legs. They feel tired, lethargic. So what's your diagnosis for this case? I said it's just a taster case, and it's mainly, as you can see, the patient was full of fluid, and he presented mainly with the increased leg swelling and also the shortness of breath. So in this case, we always think that this is more right-sided failure because of the fluid overload. So I've answered the question. I mean, you don't need to think about it, but it's if we think this is an acute left-sided failure or right or biventricular or pulmonary edema, I think it's a chronic case. It's not coming with pulmonary edema and severe distress and hypoxia to make us think of pulmonary edema. He doesn't have also like more cardiogenic shock symptoms. It's more like fluid overload. So the main diagnosis in this case would be right-sided failure. This is another scenario. It's another patient who's 55, so slightly younger patient. 55-year-old man presented with a severe central chest pain. He was known to have STEMI in the last couple of months and was admitted to the hospital after having a rest at home. He had an urgent PCI and 3 stents were fitted. After that, he was started on aspirin, clopy, simvastatin, ramipril, isosorbide mononitrate, GTN spray. And then he was referred to the cardiac rehab and has improved significantly. On examination, he's a little bit on the hypotensive side. So blood pressure was 90/60, heart rate 150 per minute, respiratory rate, he was tachypneic 35 per minute, and SATs 85% on air. Temperature was low, hands and legs looked cyanosed and cold, and peripheral pulsations were very weak and thready. Chest examination revealed some bilateral crackles and diminished air entry in both lung bases. No lower limb edema, and JVB was raised. This was his X-ray. As you can see, he's got extensive pulmonary congestion and pulmonary edema, and he's got a massive pulmonary edema picture. So what's your diagnosis in this condition? Is it acute pulmonary edema, acute cardiogenic shock, acute left-sided failure, or acute decompensated left ventricular failure, or all of the above? I'm just giving them 1 minute. I'm not sure if Dr. Ahmed are they able to text you with some answers?
Yes. Over the page of the event, there are 2 quizzes underneath the discussion board. So this is case number 2, and you can just to choose your answer if you're on the page. Just choose your answer. So we're going to give you maybe a few minutes, then I will communicate back to you the results.
1 minute is enough. It's not a difficult diagnosis here. Have you received any answer at all? Or?
I think the majority now is acute cardiogenic shock. So that's 2 of the voters, and 1 is all of the above. I can see a few are coming. Yeah.
Okay, so let's just go with the people who answered. So both answers are right, but I would agree with the one who said all of the above. And the reason why we say all of the above, because you can see from all these options, the patient has pulmonary edema, which you've already seen. The X-ray was really bad, and he has severe lung congestion. He also had acute cardiogenic shock because he presented with hypotension, tachycardia, and peripheral cyanosis, which is an indication of acute cardiogenic shock. He also had the left-sided heart failure, which is a cause of both the above, and acute decompensated left ventricular failure is a similar term, but I'm just putting it in a different terminology in case you see it, so you know that it's the same thing. So decompensated left ventricular failure, so someone already has or is known to have left ventricular cardiomyopathy or failure, and he's now presenting with a decompensated state, which would lead to either pulmonary edema or cardiogenic shock. So that's why the answer to this question is all of the above. So the reason I actually brought this question as well is I wanted just to amplify that, like when you have a patient, because sometimes people are a bit confused between the right-sided and left-sided failure, and they don't actually differentiate between both conditions. And this is a patient with heart failure. But in actual classification, we have to differentiate because that will help us to determine the right treatment of these conditions. I mean, if you have right-sided failure, it's obviously an important diagnosis and everything, but is not as bad, or the prognosis is not bad as the left-sided failure. So the left-sided failure is a bump failure, which is the main issue here. I mean, if we have a bump failure, which is the heart which is pumping 70 times per minute, as the normal heart pulsations, then it means you have a problem every second. And that would affect, obviously, the patient on the long run and will cause long-term problems more than the right-sided failure, with just a problem with filling of the right ventricle or increased pressure on the right side, which hopefully is easy to treat, rather than treating the bump failure. Because the bump failure, it's very difficult to treat. I mean, you can't really make the heart bump more or have another, improve the bump, because it's the heart at the end. The only way is to do a cardiac transplant. And as you know, that's very difficult to get a heart transplant. So in this lecture, I want to just strengthen that we should know exactly what we're talking about here. Are we talking about systolic left-sided failure, or the systolic right-sided failure, which is failure of emptying? There is another entity which some people ignore sometimes. Like, you can see that people can have an echocardiography, and it comes with a normal ejection fraction. And in the same time, the patient is still symptomatic. He has shortness of breath, and he presents with, symptoms similar to the left-sided failure, but less severe. And when we do, as I said, the echo, you find the ejection fraction is normal. So what's this condition? It's a diastolic left failure, which is a failure of filling. So the problem is the heart is not unable to dilate during the diastole to accept more fluid, and hence there is less fluid or blood inside the heart. And in that case, the heart, when it pumps the blood and distributes it to the organs of the body, it's less than what it should do. So you still got a condition of a little bit of reduced ejection fraction, but I mean, when you calculate it by when you measure it, it comes back normal. And I'll show you how we calculate the ejection fraction. But in this condition, which always happens in people who have high blood pressure and conditions which is not mainly ischemic cardiomyopathy or ischemic heart disease, it is more common now to find these people with a diastolic left-sided failure. And this condition actually is not easy to treat, but at least it can be reversible if you can correct the high blood pressure. So in terms of causes of heart failure, as you know, it comes secondary to many ischemic heart disease, which can lead to cardiomyopathy, eventually hypertensive cardiomyopathy, alcoholic cardiomyopathy, different arrhythmias like AF and other arrhythmias, valvular heart disease, which I think is more common in Egypt, hypertrophic cardiomyopathy, and other congenital cardiomyopathies, and metabolic disorders. The right-sided failure, obviously conditions related to the right side, plus reflection from the left side. So left-sided heart failure, copulmonary, pulmonary hypertension, and tricuspid regurg. So how to differentiate clinically between right and left? So we have a patient, as we said, like similar to the two cases which presented to us, which we want to differentiate now if it's a right-sided failure or left-sided failure. So on clinical examination, we just concentrate on these parts of the body. If you look at the JVB mainly raised in right-sided failure. Peripheral signs like, the hypotension, peripheral cyanosis, reduced the capillary filling, that's all more with the left-sided failure because it's a bump failure. So that's why the blood pressure would be lower than the right side. Chest examination would reveal more like pulmonary congestion and fluid in the lung, which is more related to left-sided failure. But the right side, but also remember, it's because it's a decreased filling and there's an overload in the right side. So you might still get also the crackles secondary to that, but you would find the pleural effusions are more common in right-sided failure than left-sided failure. So if you find more lung congestion, think more of left. If you find pleural effusions, think more of the right. Abdominal examination, obviously you can see the ascites, you can see the hepatic congestion and pulsations, and also the tricuspid regurg, which can be the hepatojacular reflex, you can check during the abdominal examination. Vital signs, as I explained, hypoxia and low blood pressure, tachycardia would be more with left side. Right side would be more normal or no change. As you know, this is how to look at the jugular venous pressure. So usually you have 5 centimeter of water above from the right atrium to the manubrium sterni, and then you measure the level from the manubrium sterni to the right internal jugular vein. And when you see the pulsation, see how far is it? Is it 2 centimeter? That's the normal. Above that would be abnormal. Leg edema, sacral edema, ascites. Again, same things, but I'm just trying to show it more. So raised GVB, tender hepatomegaly, bilateral leg edema, and also some complaints of anorexia, complaints of GI distress because of the stomach congestion, weight gain. Left-sided failure, more presentation of shortness of breath because of the hypoxia and the fluid in the lungs. So people always present with dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. Then they get the tachycardia because obviously if you have a low blood pressure, the heart compensates by causing tachycardia. And sometimes you can hear the gallop rhythm on the heart and the third heart sounds. Bilateral basal crepitations in the lung because of pulmonary edema. Before we had this classification, which is NIHA classification, which has been ongoing for years, maybe 30 or 40 years, and we always classify patients according to it. It didn't actually look at the ejection fraction, which is now everyone is concentrating on, but it looks mainly about the clinical symptoms of the patient and how they present. So if you have no limitation of activity and ordinary, physical activity, no problems at all, so that's class 1. Class 2, you have a little bit slight limitation of the physical activity. You're comfortable at rest, but you can have some breathlessness on exertion. Class 3, more limitation of physical activity, still comfortable at rest, but very breathless if you do a very small or tiny effort. Class 4 is uncomfortable even at rest, and you get the shortness of breath and all the symptoms even resting. So that's the most severe case of NYHA classification. Bedside investigations like ECG, ABG, bloods, chest X-ray, brain natriuretic peptide, troponin, echocardiography. That's the usual investigations we do. These are the usual X-rays we can get for people with pulmonary edema and effusions. You can see how they have these bat wings and pleural effusions bilaterally. This is the classic picture of the bat wing in upper lobes. And these are the curly B lines in less severe heart failure when you can see all these lines of lung congestion. echocardiography is very important to determine, as I said, the ejection fraction, and now the new classification will come, and I'm going to talk about it a little bit to see why do we do now the echocardiography. It's not only to determine the valvular structure abnormality or if there is any problem in the heart. Obviously, you need to look at all of that, see if there's any septal dilatation or intracardiac thrombus, any problems, but more about the ejection fraction, how to measure it, and that will reflect later on the management. So this is just a short video which would explain how to measure the ejection fraction when we do the echocardiography. Right. So this is the new classification which has been used over the last 10 years about the classification of heart failure according to the ejection fraction. So as you can see, it's very important to know the ejection fraction, and hence we can classify patients accordingly, which would help us in treatment. So some people have what we call preserved ejection fraction, and usually their signs are less than the other patients, and ejection fraction usually is above 50%. They would still have some elevated levels of natriuretic peptide. They might have one or two criteria like the LVH or diastolic dysfunction. So more, as I said, the preserved ejection fraction would be more diastolic dysfunction. The people who have a mid-range ejection fraction, it's between 40 to 49%. They have still elevated natriuretic peptide, and they might have similar, like also LVH or diastolic dysfunction. Now, what we're concentrating on, or what people have really put all the research on now, is this is the heart failure with reduced ejection fraction. So when the ejection fraction is less than 40%, now we have to consider these people as at most danger, and we have to concentrate on the treatment in a graded way. So there is a special algorithm, which we will go through it in a bit. Generally, as you know, just improve the quality of life, reduce symptoms, improve prognosis. That's all our aims in management. And how to reduce symptoms, usually if you have someone with edema or lung congestion, we give diuretics, as you know, like loop diuretics or thiazide diuretics or spironolactone. If you have shortness of breath and cough, beta blockers, vasodilators. Treat the cause, which can cause the heart failure itself, like antiarrhythmics, antiplatelets, anticoagulants for AF, antihypertensives, and now the new treatment. So if you follow this algorithm, I'll go through it step by step because it's very important in your way of thinking. So now we just took this group of patients who have a reduced ejection fraction less than 40%. And we start with a treatment as we usually give to any heart failure patients, with a beta blocker and ACE inhibitor. Okay, so that's the mainstay of treatment of any patient with heart failure, as you know. Beta blockers, the main aim to give beta blockers is to reduce the heart rate, obviously, give more time for diastole, and that will improve the circulation also to the heart when you slow the heartbeats, and help regeneration a little bit of the heart, and then the contractility of the heart will improve, because we said this is a pump failure. ACE inhibitor, as you know, the ACE enzyme, they found it's the most lethal enzyme in the all the blood vessels and in the heart, and it can cause a lot of like growth factors and inflammatory mediators, which will cause increased, like degeneration of the heart and makes it more cardiomyopathic. So it's not only about being a vasodilator, which why we use it in hypertension or other conditions, but in the heart in particular, it helps with mortality, reduces mortality, same like the beta blockers, because you like get rid of the angiotensin enzyme, which is the most dangerous enzyme to the heart and to the blood vessels. It does cause also some vasodilatation and improve the diastole, but the main cause of giving an ACE inhibitor, as I said, is mainly improve the growth factors and effect on the long term of heart failure patients. So if you give these two medications and they are still in symptomatic with shortness of breath and feeling tired, lethargic, and all of these symptoms, ejection fraction still less than 35%, then you have to add a mineralocorticoid antagonist. And also the reason for giving the mineralocorticoid is to help with similar to the giving the ACE inhibitor, because it stops the angiotensin. The mineralocorticoid antagonist like spironolactone or amiloride, in that it's a weak diuretic, which would intensify the other diuretics you've given already, like furosemide or thiazide, but also in the same time it stops the renin angiotensin pathway, which is the same mechanism. So if you stop the renin angiotensin pathway, which has already produced or stimulated the aldosterone, so it's like an aldosterone antagonist, so you also stop it from affecting. That's why we have used spironolactone. Even in a very small, they found this reduces the mortality quite a lot. If there is no symptoms, you can go to the next step, which is no further action required. Okay, you just maybe receive the diuretic dose. But let's go through the yeses first, and then the no's easy. So you've given now a mineralocorticoid antagonist, and the patient is still symptomatic. So you look clinically, the patient is still able to contract an ACE inhibitor or ARB, angiotensin receptor blocker, still tachycardic, and also has a prolonged QRS duration. So now the next step is to give the ARNI, which is angiotensin receptor related inhibitor. This replaces the ACE inhibitor. So now we inhibitor and add SACU and valsartan, which is a combination of two drugs which have a diuretic as well as an ACE inhibitor effect. But they found that the new studies, when both are joined together, they have a stronger effect on also the angiotensin and the aldosterone system. So they are quite useful to give that. And then if you have a sinus rhythm with a QRS duration above 130, there is a need now to consider CRT, which is cardiac resynchronization therapy. If the heart rate is above 70, you consider ivabradine. Ivabradine, we're going to talk about it in the next slide, but it's one of the new medications which has also started over the last 10 years. In the beginning, it was only given by cardiologists, but I think now, even as a general physician or acute physician, you can prescribe it because it does help with heart failure symptoms and tachycardia. You can give all these medications combined, and if you still have resistant symptoms, then you can consider digoxin or cardiac transplantation, which is obviously the last resort. If no further symptoms after you give all of that, so you just continue with the same management. So ivabradine is indicated in patients with symptomatic heart failure with reduced ejection fraction, less than 35%. The patient must be in sinus rhythm, so you can't give it in AF, okay? And the heart rate should be above 70. It has been used for patients with heart failure who have been hospitalized within the last 12 months, and it does help to reduce the length of stay for patients and improve a lot the heart failure symptoms, and has been suggested now by the European Medicine Agency and NICE guidance to give this medication. The main side effects is bradycardia and blurred vision, and hence we can't really give it to people who have bradycardia. They must have a heart rate above 70. The sacubitril and valsartan is indicated in patients also with the same criteria. Ejection fraction should be less than 35%, and they must have a raised brain natriuretic peptide. And also the GFR should be reasonable, because most of these patients have what we call cardiorenal syndrome with a low GFR. So because it has an ACE inhibitor in it, so it might affect the kidney. So you have to be careful with people who have end-stage renal disease. Side effects, hypotension or risk of angioedema, similar to anyone on ACE inhibitor. The cardiac resynchronization therapy has been also ongoing for a while now. I don't know if you know about that or not, or it has been common in Egypt. But the cardiac resynchronization therapy, it's the same pacemaker we put for any patient with, like heart blocks or any arrhythmia. But the difference, it has 3 leads rather than 2 leads. And the 3 leads, one of them will go to the right atrium and one to the right ventricle. And this is what the normal pacemaker does. Or sometimes they have 1 lead pacemaker, like to go to the right atrial lead when you have just a problem with heart block or whatever. But if you have someone who has, I'll just tell you the criteria of the CRT, but I mean, this is the 3rd lead, which goes to the left ventricular coronary sinus lead. So this is the 3rd one here. So 2 leads to the right side, right atrium and right ventricle, and the 3rd goes to the left ventricular coronary sinus lead. The indication for that is these patients, when they have severe cardiomyopathy, they develop left bundle branch block, which means that there will be an alternate contractility between obviously the right side of the heart and the left side of the heart. So the left side will be delayed because of the left bundle branch block. and that would cause more symptoms of tachypnea and low blood pressure, and it's much more pronounced with low ejection fraction as well. So if you have a low ejection fraction plus, dilated heart and left-bundle branch block, it means the heart contractility will get much worse, and there is a delay also in sending the impulses to the left ventricle. So in this case, if you have dilated cardiomyopathy, low ejection fraction less than 40%, and left bundle branch block picture in the ECG, or what they call it like wide QRS complexes, these are the three indications of putting a CRT. So it doesn't apply to everyone. They must have left bundle branch block as well as the other criteria, the low ejection fraction and heart failure. That's the same, just a cartoon image here. So put a lead in the right atrium, another one in the right ventricle, and the third in the sinus, coronary venous sinus on the top. Now we talk about the acute stage, which is my work. As I said, I work as an acute physician, so I see patients mainly when they present to the hospital with acute pulmonary edema or acute decompensated left ventricular failure or acute cardiogenic shock. As I said, all the other terms I mentioned before. So you have to give patients oxygen 100% high flow. You might need to give them CPAP as a non-invasive method of improving oxygenation in the lung. You give IV GTN infusion, and also you administer some furosemide if the blood pressure is allowing. Right, so I finished my talk now. I don't know if anyone has any questions. Can we go back to the other screen, Dr. Ahmed?
Yes, there is a quick question, I think, from Dr. Fatima. She says, "What's the best to start? What's the best to start with in terms of mineralocorticoids, and is there any restrictions in renal transplant?"
Right. So, the best one is the spironolactone. In renal transplant, if they have functional kidney, we always look at the GFR. If the GFR is above 40 or 50, and the kidney functions, I mean, basically they are normal, we can still give the similar medications to what we give to normal patients, but depends mainly on the GFR.
I think you're still sharing the screen, Dr. Abusaif. So if you want to switch off the screen.
Sorry.
There is a bit of delay anyway between the live streamed version and the seen version of the talk. So there's probably, I think, 30 seconds or maybe 1 minute. So you might need to wait a little bit for the questions to come over. But meanwhile, I've got like two main questions, if you don't mind. So one of them is about the availability of echocardiography in many patients. So, I mean, in Egypt, we know that probably the affordability of doing echocardiography might be less than the availability of doing echocardiography here in the UK. So, is there any proxy? Because my understanding is this classification, this new classification, is mainly based on the ejection fraction, which my understanding as well will need echocardiography to accurately measure it. Is there another proxy to get to that classification without doing echocardiography? Is there any alternative that we can use to guide our clinical?
There is no alternative, but I'm pretty sure the echocardiography is very, very well established in Egypt for a long time. I mean, even before I came to England, we used it all the time, everywhere, and all cardiologists actually are very good in doing echocardiography. It's not that expensive at all. It's very similar to doing an ultrasound in Egypt, so I don't think there is a problem. I mean, if anyone from Egypt can correct me. But I remember, as I said, it was one of the easiest things you can do, and you can do it even bedside. Measuring the ejection fraction, even just as one thing, rather than checking on the valves or anything, you can do it in less than 1 minute. Um, so I don't think there is a problem, to be honest, Dr. Ahmed, about doing an echocardiography. The good thing even about echo in Egypt, that the doctors do the echocardiography, while here in the UK it's done by technicians, which I think for patients is better to be done by doctors because they will understand more about the structure of the heart.
Okay, so my other question was about. So you mentioned that you normally like see patients in the acute stage when they're presenting to the hospital. So in terms of managing those patients, like on the long term, do you manage them like yourself, or do you normally like refer them to a cardiologist? Who should take the lead in managing these patients, and what is kind of the line between you and the cardiologist? So when exactly we say, okay, that's my role, so I've done my job now, we need to send them over to another colleague in cardiology?
Right. So, to be honest, in England here, I'm not sure about the Egypt, managed by medics, medical minimum for failure, ischemic heart disease, and like are much busier rather than treating heart failure with diuretics or oxygen or morphine or whatever. So they leave it to us. So we only tell patients with heart to the heart specialist. Like, for example, if someone has very severe hypotension, and he's also on the same time has a severe lung congestion and very overloaded. So you're stuck here. You can't give any diuretics, you can't give GTN, and you need something to help, which is either a CPAP or some what they call it, I forgot now, but I mean they do like intra-aortic pressure to help raise the pressure inside the heart. Or you can give them some dobutamine to improve the cardiogenic shock, and after that you diurese them. But in these situations, they have to be in CCU, and obviously that can only be managed by cardiologists. But the usual heart failure we see in the hospital, like the pulmonary edema, lung congestion, some right-sided failure with lower limb edema, and ascites, stuff like that, we are able to manage under medical wards rather than getting the heart specialist to treat that because of the amount of patients we see.
I'll keep my other questions to the end, but there is a quick another question from Dr. Tariq Kamil. He says, which is better to start with, diuretics or nitrates in managing, I presume, in managing heart failure?
That's a good question, very good question. I always start with diuretics because diuretics are very helpful in managing the very acute situation. So if someone coming with severe pulmonary edema, they can't breathe, they always tell you, oh, doctor, I feel like I'm suffocating, I can't take a breath, all of that, Once you give them a stat dose of furosemide, 40 or 50 milligrams, they start to have less, symptoms, and the symptoms improve immediately. While the GTN takes a while to get rid of the fluid, but so we give both anyway. So we start with the diuresis because it works within a minute or two, and then you put them on the GTN, which you can start with a very low rate in the beginning, like between 0.5 to 1 ml per kg. and you can build up later. So the GTN infusion helps, like on a long term, you can leave it for 24 hours to work. And you start with a low rate, and then hopefully when the preload improves, then the contractility of the heart will improve, and then you can increase the level of the GTN. And the GTN in the beginning also, you can give it for people who have low blood pressure, like even 90/60, or you can't give it for less than 90/60. But if you start with it and the blood pressure goes low, then you're not able to give any diuresis. So I would prefer to give furosemide immediately, because the blood pressure can be still on the normal range, and after that it will drop, obviously, after you give diuretics. So hence you can start the GTN infusion after that.
Okay. One last question. I think we've got to probably 4 or 5 minutes to finish this. What are the criteria for admission? So does any patient with heart failure, does any patient with heart failure need to be admitted to the hospital? Is there in a room for community management? And what are the criteria for discharge? At what stage you would say, okay, that's okay. I mean, we can manage the patient at home.
There is a big room for community management, which also I'm not sure if that exists in Egypt. But so what you asked me about before, if the cardiology team likes to be involved, in management of heart failure. To be honest, the doctors maybe no, but the nurses are more involved, because we have what we call a heart failure team, which is built mainly of nurses. And the nurses are special nurses only in heart failure. So their job is to check on the ejection fraction, know the medications the patient take, and titrate these medications, especially when they go home. For example, increase the beta blockers, increase diuretics, or then reduce them after improvement. So they are very, very specialized in that. And if they reach like a bad state, or they need to be admitted to hospital because the medications are unable to work orally, so that's the only indication you get them to hospital, because you need to give them IV furosemide, for example, because it's not absorbed by the stomach because of stomach congestion. So you need to admit them to hospital to give it through IV route. But I mean, the community heart failure team is very active, and is a very good team. It helps to reduce the amount of admissions, which, as I said, is a very huge, big number of patients in the community who need to come. And they come recurrently, like you can't really get rid of them because they don't improve. So if they get followed up in the community, they stop the admissions. More than, I would say, 50 or 60% of admissions are stopped by community nurses. The other action also of the community nurses is they help with deciding, for example, if this patient needs to have the CRT, or if they can have one of these new innovations in treatment. And in that case, they liaise with the cardiologist and start the medication for them. But I mean, the only reason for us, we have criteria in the hospital, like we can't, for example, if someone comes with new onset heart failure, we are not allowed to refer them to the community heart failure team unless the ejection fraction is less than 40%, which what we said, this is the new criteria now, the reduced ejection fraction.
Okay. Just one last question, and we'll end with this. That's a question from Dr. Rola Uthman. She says, if we have normal echo with high BNP, is it a silent heart failure?
It's I think the other, if you followed the talk from the beginning, it could be the diastolic heart failure, which can be, I think that's why they call it silent, because it's a sort of heart failure, but patients don't know because they measure ejection fractions normal. But when it comes to presentation and clinical signs, patients are very symptomatic and they have very high BNP. But we have to be very careful with these patients, because if you reduce the preload very much, the heart failure might get worse, because you are reducing the amount of fluid or blood going to the heart, which we have a problem with filling the heart because of the diastolic heart failure. So the diastolic heart failure, you can't really give loads of diuretics or beta blockers. Maybe you concentrate more on giving ACE inhibitors and the ivabradine if they have a normal heart rate.
Okay, I think that said, Dr. Nihal, it's nearly 2 minutes to 1 p.m. in UK and 3 p.m. in Egypt. I'd like really to thank you very much for your time and for sharing your knowledge. For our colleagues who've managed to join us, if you've got any other questions, please leave them in a comment. Also, if you would like to hear from Dr. Abu Saif about any specific topic, write like your recommendations in a comment, and we will try to get in touch with Dr. Abu Saif to maybe arrange another talk about that topic. Also, Dr. Nihal, if you don't mind, if you can maybe share the slides. And Dr. Nihal is on Saha Sky as well, so she's on the platform. If you would like to communicate with her directly, you might be able to find her profile on Saha Sky. I'm sure Dr. Nihal has always been very helpful and very cooperative. Thank you very much, Dr. Nihal. And if you would like to maybe to have a final word, and we'll finish now.
As I said, we're very happy in Saha Sky to help people in the Egypt and other Arab countries, and we're welcoming all suggestions, questions, and if you want any more topics, let me know. I can also help with recruiting other consultants to give these talks for you if you want like a specialized talk. And even if you want any advice about coming to the UK and you want to know how to come and what to do and all that, I know that a lot of people interested in coming abroad. I can give you some advices. I also have some talks about communication skills in the UK and how to apply and like CV writing and job interviews, all these stuff which people like to hear. So if you're interested in any of that, let Dr. Ahmed know, and hopefully we'll arrange another session for that.
All right. Thank you very much, Dr. Nihal. Thanks for those who've managed to join us.